Right, today we are continuing with our lectures on leukemias. Already we had lectures on the first 3 videos which we made. That was about an introduction to leukemia. Then we discussed about acute lymphoblastic leukemia, lymphoma. Today we will continue with the lymphoid tumors, and we will talk about chronic lymphocytic leukemia, lymphoma, right? Chronic lymphocytic leukemia, right? Chronic lymphocytic leukemia / small, yes, lymphocytic lymphoma, or in an abbreviated way we can write that there is CLL, right? There is CLL, chronic lymphocytic leukemia / SLL, that is small lymphocytic lymphoma. Now, before really I go into detail of lecture, I would love to mention why these two categories are put together. What is the real thing common in them, and what is the real thing which is different in them? There must be something common they are put together in most of the medical literature presently, and there must be something different. That is why they are given 2 names, but they are put together. When we say chronic lymphocytic leukemia or small lymphocytic lymphoma, basically the common thing in these 2 conditions is that both of them have small lymphocyte, mature lymphocyte, as relatively mature lymphocyte as leukemic cell. That in this condition, the leukemic cell and its biology in both conditions is the same. But we really see that leukemic cells are basically not large cells, right? You remember acute lymphoblastic leukemia where the malignant cells or neoplastic cells, the leukemic cells were large cells.
Yes.
They were lymphoblast, right? In acute lymphoblastic leukemia, lymphoma, the malignant cells were lymphoblast. Here, in these conditions, the leukemic cell is lymphocyte. And when we say there's a lymphoblast in my hand, this hand, and the lymphocyte in this hand, let's suppose if I say this is lymphoblast and I say these are lymphocyte, the name tells a lot. When I say lymphoblast, it means it's rapidly proliferating. When I say lymphocyte, they are not rapidly proliferating, right? When I say lymphoblast, it means they are relatively immature. When I say lymphocyte, they are relatively more mature. When I say lymphoblast, it means they are rapidly, yes, proliferating. And if they are rapidly proliferating, then they are rapidly duplicating their DNA. And if they are rapidly duplicating their DNA, their chromatin should be open.
Yes.
And if I say the lymphocyte, I mean they are mature cell, it means they are not rapidly proliferating. It means the chromatin is not open. It means the chromatin is condensed. Because usually when cells are rapidly replicating, when cells are rapidly dividing, their chromatin is open and all DNA is undergoing the process of duplication. Is that right? So we can say the very important thing between ALL and CLL versus SLL, that here were lymphoblasts which were large cell, here are lymphocytes which are small cell, here there was a bigger nucleus, of course, here the smaller nucleus, but still nucleus occupies most of the cell, and there is very scanty cytoplasm here. Here also nucleus is very large, but as compared to this lymphocyte, this is lymphocyte, this is lymphoblast, here chromatin is relatively
Open
loose, right? Less dense. That is why blast cells look pale. Again, I will repeat it. Usually immature cell and rapidly proliferating cells are larger and paler, right? They look pale. And with staining, they stain less dense. But when we talk about more mature cell, less dividing cells, usually in lymphoid series, they look smaller and their nucleus look condensed. Am I clear? So first I made the difference between that when we talk about acute lymphoblastic leukemia, lymphoma, we are talking about lymphoblastic cells which are rapidly proliferating. And when we are talking about chronic lymphocytic leukemia / what? Small lymphocytic lymphoma, here the cells are small and less rapidly dividing and mature looking. So really when we talk about these cells, which are, what are these cells? These are small, mature, relatively mature looking lymphocyte, small mature looking lymphocyte, yes, with which kind of chromatin? Sites with, yes, condensed chromatin, condensed chromatin and scanty, yes, very little, scanty cytoplasm. Is that right? Now, question is that, as I told you in the beginning, that both of these conditions, small lymphocytic leukemia, chronic lymphocytic leukemia and small lymphocytic lymphoma, both of them have same cell which is malignant. Cell's biological behavior on the both sides is same. The major difference being that this is leukemic situation, this is lymphomatous mass. As I told you in the beginning of previous lectures, when we say there is leukemia, it means there is widespread involvement of bone marrow and there is heavy infiltration of the blood by the leukemic cells. But when I say that condition is lymphoma, it means it is making somewhere in the body solid, cohesive, well-defined mass or discrete mass. So it means when we talk about small, mature looking lymphocytes, right, and usually these are peripheral B cells. These are peripheral B cells, right? Because most of the chronic lymphocytic leukemias or small lymphocytic lymphomas, they are derived from the B cell line, right? These cells have surface markers of B cells. So we say these are the tumors of peripheral B cells, right? Peripheral B cell neoplasia. Now, we already know what is the difference and what is the commonality. If someone asks what is the common thing among them, that is the cell type. Leukemic cell is same. But what is the difference in them? That is the tissue distribution. Here the tissue distribution is leukemic fashion. Leukemic fashion means widespread bone marrow involvement and heavy infiltration in the blood. Is that right? It means there will be lymphocytosis, and lymphocytosis in the blood is characteristics of chronic lymphocytic leukemia. And in small lymphocytic lymphoma, even though the cell biological behavior or origin of cell is similar, but it is not heavily infiltrating the blood. So it means here there will not be lymphocytosis. If here was lymphocytosis and significant lymphocytosis mean, here the diagnostic point is, most of the authority believe significant lymphocytosis is 5,000 absolute lymphocytosis is more than 5,000 per microliter. Even though some authorities which are more sensitive, they believe in the blood, if absolute lymphocyte count is more than 4,000, it is pointing to the diagnosis of leukemia. For complete diagnosis, we need other parameters also. But what I'm trying to say, chronic lymphocytic leukemia, heavy infiltration in the blood by the small lymphocytic cells. But how much is really heavy? How much lymphocytosis will make you alert that there is a chance of this disease? The answer is, majority of the authorities believe that when in the peripheral circulation, absolute lymphocyte count is 5,000 or more per microliter, you must consider what? Chronic lymphocytic leukemia. And of course this elevation should be sustained over time. This elevation of this absolute lymphocyte count in the peripheral blood should be sustained. These are leukemic cells, neoplastic cells, they should show sustained elevation. But again, when we are talking about these cells, as compared to normal B cell, how do they compare? Listen, already we compared them with lymphoblast and mature looking lymphocyte, which are leading to this leukemic situation. But how do they differ from the normal B cell? This is very, very important, right? So let me tell you. There are few things which are common. Just looking at the cell may not tell you enough that it is leukemic or not. Let's suppose this is normal B cell, right? This is normal B cell. Now, what is the difference in normal B cell and leukemic B cell, which may be involving this condition or that one? Okay, there are few things common. few things different. First, I will talk about the common things. Both of them are small. Both of them have condensed nucleus. Both of them have scanty cytoplasm. This is common. It means at cytological level, if you simply look at the cells, they look similar, right? But what is then? There are surface marker on the B cells. You know, different lymphocytes have special type of proteins on their surface, and by those proteins or combination of those characteristic proteins, we can recognize what kind of lymphocyte or lymphoid cellular element is there. Now, pan B cell markers. Pan B cell marker mean which are present on pan B cell markers. Pan B cell markers are the proteins, right? These are called cluster of differentiation proteins, right, which are present on the most of the B cell, right? Now, pan B cell markers are present on most of them. Now, classically that is CD19 and CD, let's suppose this was CD19 and here is CD20. Is that right? Now, on this leukemic cell, it also has CD19. It also may have lower level of CD20. So it means by studying these two markers on these cells, we can confirm that this cell is B cell. This cell is B cell, but it doesn't tell it's malignant or not. Is that right? But then there is another marker which is specially present on this cell and which is not present on most of the B cell, right? That special marker is present very abundantly on these leukemic cells, that is called CD5. CD5 is a marker which is normally present on T cells. Actually, CD5 should be considered a T cell marker. Actually, let me tell you, in the past, we were to define that a specific lymphocyte is T cell or not, we were looking for CD5 for T cell, right? Later on, we made the monoclonal antibodies against the CD3, and they were more sensitive to identify the T cells. But what I really want to highlight that CD5 is a classical marker of one of the important surface marker of T cell. But in these leukemic B cells, they are there. You know, this point is so important that if by immunophenotypic technique, if you fail to demonstrate CD5 on this cell, you have to think a lot before you put this diagnosis. That's right. Right? Am I clear? Normal cell does normal, what is this? B cell do not have CD5, or some of these cells have very low expression of CD5, right? But they have very heavy expression of. So classically, for the diagnosis of this condition, CLL and SLL, right? What should be the number one thing? That cell should be B cell. To prove B cell, it should be CD19 positive. With that, there should be co-expression. The word is used, co-expression of CD5. CD5. CD20 may or may not be there, right? But real classical thing is that in this tumor, even the diagnostic point, this is one of the diagnostic point, but by immunophenotypy, we must be able to demonstrate presence of CD19 and CD5 on these leukemic cells to put the diagnosis. Now, CD19 and CD5 positive. Is that right? This is one thing. Now, these two features, cells, small cell, condensed nucleus, scanty cytoplasm, which are CD19 and CD5 positive, and they are present in abundant, unusually high number. Unusually high number points to this disease. If very high number is only in lymph node or other tissue and not in the blood, then this should be considered small lymphocytic lymphoma. But if these cells are abundantly present in peripheral circulation, especially more than 5,000 per microliter absolute lymphocyte count, these cells with co-expression of these two, then it should be considered chronic lymphocytic leukemia. Am I clear?
Yes, sir.
There's no confusion? Anyone who is confused, raise your hands. Everyone has two hands. Yes, just to remind.
I was confused a little while ago, but now I am clear.
Now you are clear? Okay, that's very good. I'm very glad that in the end you also understand it. Great. Now, there's a little problem. There's another condition, but this is for some very good student, not for average student, but some doctors are really good. Maybe you are one of those. Actually, there is another lymphoma which is called mantle cell lymphoma. Problem with the mantle cell lymphoma is its cells are also CD19 positive and they are also CD5 positive. Now what to do? Don't worry. There's an additional marker here. This additional marker is CD23. It is not present on those. Right? So let me brief first of all this condition. That what we are talking about peripheral B cell neoplasia. We are specifically focusing today's our lecture on chronic lymphocytic leukemia and small lymphocytic lymphoma. Now onward in lecture, I will call them CLL, SLL. What I will call now onward in the lecture, CLL, SLL. Now, what is this condition? This is a condition, this is a leukemic condition in which there are leukemic cells which are small lymphocyte, maturely looking lymphocyte with condensed chromatin, scanty cytoplasm. Usually lymphocyte size is 6 to 12 micron, the small size, right? Around 6 to 12 micron. So with these lymphocytes, diagnostic point come, strong pointer to diagnosis, which express pan B cell antigens, right? Along with CD5. Many students in the MCQs, they make it wrong. When they look at CD5, if they remember T cell, they are confused. Yes, I agree, this is T cell marker, but it is present in this leukemic situation. Is that right? And so, secondly, when we are talking about that it is CLL or SLL, in both conditions, such cells are abundantly present in body. But if they are infiltrating the blood heavily, right, then it is leukemia. And if they are only in lymph node or spleen or some other tissue making discrete mass without heavy infiltration in the blood, then it is SLL. Am I clear?
Clear.
Any question up to this?
Yes, sir.
There's no question. Yes, you have a question.
Sir, is CD23 always present on leukemic B cells?
Yeah, this is a very interesting thing. He has asked that is CD23 present always in leukemic B cells? Almost always present on leukemic B cell of this category. Because there are many other leukemias like hairy cell leukemia, that is also B cell leukemia. B cell leukemias are many types. Right, the hairy cell, the Burkitt's lymphoma, I mean similar conditions are there, right? But as far as this is concerned, CD19 and CD5 are required for diagnosis. But for differential diagnosis, if you are really confused, most of the doctors don't get confused because clinical picture is usually very clear, right? If patient present in advanced stage. But if patient present early, then it is asymptomatic. I will tell you this later. But most of these patients have CD23. But must requirement is CD5. Am I clear? Yes.
So then why don't we go for CD23 on the first place? We'll have
Because CD23 may be present in some other cells also which are not leukemic.
But sir, then we'll be sure that it is not a mantle cell lymphoma.
Listen, the thing is that CD23 is present in many other conditions. Is that right? But the thing is that other conditions don't have CD5 positive. Do you got it? For example, there is a cell here, a funny cell, maybe it's CD19 and it is also CD23, but it won't have CD5. So your question made me further stress. Don't forget your friend CD5. Right? When you go to CMDT, what is CMDT? 2014? Current medical diagnostic and therapeutics edition 2014. They say for CLL diagnosis only two things are required. Number one, abundant small lymphocyte, especially in the blood more than 5,000 per microliter, plus co-expression of CD5 with CD19, these two. Then if you are really so confused with the mental, you confirm the presence of CD23. Am I clear? Okay. So can we move forward? Another condition which I would love to mention, when it is SLL, for example, these pathological cells are present as a discrete mass, then they can be, this is small lymphocytic lymphoma. Is it Hodgkin's lymphoma or non-Hodgkin's lymphoma? Yes. Who is good? When we talk about lymphomas, we divide lymphomas into two basic categories, Hodgkin's lymphomas and non-Hodgkin's lymphoma. We are saying if this abnormal cell is present as mass in your body or any patient's body as a discrete mass, right, with these markers, this is SLL, small lymphocytic lymphoma. Is it Hodgkin's lymphoma or non-Hodgkin's lymphoma? Oh my God, it is non-Hodgkin's lymphoma, because non-Hodgkin's lymphoma are having Hodgkin's lymphoma are positive for Reed-Sternberg cells or its variants. Is that right? And if it was Hodgkin's lymphoma, it will not be discussed here. Hodgkin's lymphoma category goes entirely separate. So it must be non-Hodgkin's lymphoma. If it is lymphoma, then we must think, is it which lymphoma, Hodgkin's or non-Hodgkin's? It is understood it should be non-Hodgkin's, because Hodgkin's lymphoma category in lymphoid tumor is entirely separate, and that is characterized by the presence of Reed-Sternberg cells and its variants. Is that right? So it means that non-Hodgkin's lymphoma is a very big category. And out of that very big category of non-Hodgkin's lymphoma, it makes only 5% of non-Hodgkin's lymphoma. SLL makes only 5% of the non-Hodgkin's lymphoma. Previously, this was considered separate entity as non-Hodgkin's lymphoma. This was considered separately as chronic lymphocytic leukemia few years back. Now we put them together. Why? Cells of origin, cell biological behavior, underlying phenotype, underlying molecular pathogenesis and therapeutic responses are similar except tissue distribution. Am I clear?
Yes.
No question? Okay. Now this condition, this leukemia, CLL, whenever I say now onward CLL, you consider I'm saying also SLL. Yes. Right? Just make it simple. Whenever we talk about CLL, it is the most common leukemia in elderlies. You remember in previous lecture we talked about most common leukemia in children, pediatric leukemia. Yes. The most common leukemia in children was ALL. And ALL, acute lymphoblastic leukemia, lymphoma. And in elderly, 60 and plus, 60 year and plus, right? Actually from 50 year onward, the incidence of CLL progressively increases. So it's a leukemia of elderly people. So we can say that 60 year and plus, right? Most common leukemia, especially in the Western world, because this leukemia is less common in Japan and other Asian countries, Japan and China. So in the Western countries, right? Especially in Western countries, most common leukemia in elderly is CLL. Is that right? And it's more common in males, 2:1 ratio. Right? Whenever one female suffers with this condition, there are two males in competition to have this one, unfortunately. And right, again come back. When we talk about most common pediatric leukemia, you should think of acute lymphoblastic leukemia. We discussed last time. And when we think of the elderly, 60 plus years, leukemia, right, small lymphocytic, most common we should think of chronic lymphocytic leukemia, right? Now, I will again stress further on immunophenotypy, but before really I go for immunophenotypy, we always say the instrument which is used for immunophenotypy, that instrument is called cytoflowmeter, and technique is called flow cytometry. What is that technique called? When we are talking about on a given cell, we detect. I will go into little more detail of immunophenotypy because it's of diagnostic importance. So we say that in these patients we do flow cytometry. Now what is flow cytometry? Flow means flowing, cyto means cell. Flowing cells are measured, counted. What is flow cytometer? This is an instrument as name that cells are flowing into a line. Cells are flowing into a line and they are numbered. Now, actually how it works, flow cytometer, I will give a very simple diagram, but actually things are not as simple as they look at my diagram, right? There are many types of flow cytometer and there are many different purposes, but I will give you an idea that let's suppose you take a blood sample of the patient, right? And you put here drop of blood, and it is in such a way that these lymphocytes or different cells, or let's suppose from the blood you remove the lymphocytes, this is so thin, it's so narrow that each lymphocyte is moving in a line. In one line, lymphocytes are flowing. And here what we do, we have special type of, we can say, antibodies in this. Let's suppose, here it is, you remember our leukemic cell was CD19 positive and yes, CD5 positive. How do you know that a specific cell is CD19 positive or CD5 positive? I will give you a very simple idea that from the cells we remove CD19, right? Scientists have already done it, and CD19s are injected to some animals, right? And those animals make antibodies against the CD19, and those antibody making plasma cells are separated, and they are made to multiply and secrete antibodies in the laboratory, and those antibodies are anti-CD19. For example, these are the antibodies which are made, and these are anti-CD19. And let's suppose this is CD, yes, what is it? CD5. And this is also in the same way we get antibodies directed against CD5 molecules, protein molecule. So in this way we can have anti-CD5 and anti-CD19 antibodies. These antibodies are called monoclonal antibodies because the clone of cells which produce these antibodies or those antibodies, these antibodies clone. The clone of cells which produce anti-CD19, they are genetically identical, they are derived from one cell. We call them monoclonal antibodies. So in one side, let's suppose we put here antibodies, which antibodies? Anti-CD19. And here is a stopper. The company which make flow meter, if they look at my diagram, they'll commit suicide because I made it so simple and they're charging so much for this thing. Anyway, so, and what is this? Anti-CD5. We have put it. Now another thing which we have done in the laboratory, that we have put fluorescent tag here. What is this? Fluorescent tag. There we have put a special type of molecule here. When fluorescent light fall on it, this will illuminate. It will sparkle, illuminate. Now you see what we do. We let the cells pass through it, right? And here is a lamp. This is fluorescent lamp, fluorescent light. And here is a counter. What is this? Counter. A system which counts how many cells are flowing through that. They are detecting the cells. Now what happens? Counter should come a little away. Here is the counter, suppose, right? This counts the cells which are passing by. Now what really happens? Let's suppose if this cell is B cell, when B cells are passing through this, we release anti-CD19. What is this? Anti-CD19. And when we release these antibodies, if there is CD19 on these cells, these antibodies will react with that. And what will happen to this cell? For example, this is CD19, this is CD19, right? So these antibodies will bind over. And they are having what here? Fluorescein, right? Fluorescent tag. Now what will happen? When these antibodies get these cells which are expressing CD19 markers, if anti-CD19 antibodies are pumped here, they will get coated. And when they will be passing further and reach to this area, what will happen? When fluorescent light is thrown, this cell will illuminate. And how many illuminations occur, this counter will count. So it will tell two things. Number one, this is CD19 positive or not. Secondly, how many cells were CD19 positive. So not only it detects the presence of CD19, it also detects how many cells are positive and how many are not. Am I clear? In the same way, then we stop this stopper and we add this one, right? Or continue this as well as this. If the cell is only CD19, right? Let's suppose this cell is only CD19 positive, right? It will have only flow reaction to this. But if it is CD5 positive as well, then it will react to these as well, right? So this is a simple concept of flow cytometry, which is used to detect the what? Special surface marker on the cells, right? Now, these surface markers, once you know it, this process is called immunophenotypy. Why we call it immunophenotypy? Look, genotypy means what is going inside the DNA. Phenotypy is what is going on the surface of cell. In this regard, when we are talking about B cells, when we talk about genotypy, we are talking about genome. Phenotypy means that what kind of markers are expressed here, right? Now, because this typing of the phenotype is done with the help of immune system, antibodies, so that is why it is called immunophenotypy. So now onward, if someone asks you that in CLL, right, if you do, what are the investigations you need to do for CLL or SLL? The thing is that one of the important investigations will be flow cytometry. What is the purpose of flow cytometry? You want to do immunophenotypy. And immunophenotypy, what it will tell you? It will detect the presence of different surface markers, right? So we'll go back. Already we discussed pan B cell antibodies. CD19 is there. There may be CD20 as well, but really most important here is CD5, right? This is one thing. Now another thing. This cell, the tumor is there. Now this tumor cells, when a person develops chronic lymphocytic leukemia, these are lymphocytes, even though they look normal, but actually they are abnormal. Actually they are abnormal, right? Now these normal looking functionally dysfunctional cell, they are not fully functional cell. These cells, do you think they can be stimulated like normal B cell and forced to make antibodies? Answer is
no.
No. These are rogue cells. These are dysfunctional cells. These are not normal cells. So we use the term that these lymphocytes are biologically, functionally, they are incompetent. Immunologically, they are incompetent. Immunologically, they are not responding properly to the antigenic stimulation. These leukemic cells, these small lymphocytes, which are leukemic, even though they look like normal, but they are immunologically incompetent. They do not have capability to respond to the antigen properly. Am I right?
Yes.
Clear? Yes. And another trouble. Most of the time, now listen very carefully with your both ears. Many cells in our body, many lymphocytes in our body, during proliferative process are produced which cannot react well to an antigen. You know what our normal system does? Forces these cells to undergo suicide, process of apoptosis. During lymphocytes development, such lymphocytes which are produced in our body, which cannot respond properly to the immunological stimulate, they undergo the process of cytological deletion, or we say they are forced to commit suicide, or medically speaking, they are forced to undergo apoptosis. The problem with these cells is they are not only abnormal. If they are abnormal, they should undergo apoptosis. But if they undergo apoptosis, from where you will get the cancer? So actually they have another trouble. Number one, they are abnormal, right? And number two, they refuse to die. They are reluctant to undergo apoptosis. So they are slowly small, maturely looking cells which are slowly dividing because they are not blast. If they were blast, they will be rapidly dividing. So slowly dividing, immunologically incompetent, unable to respond to antigenic challenge and unable to serve us, but at the same time they are very resistant to the death process, cellular death, apoptosis. They are reluctant to die. They have prolonged lifespan. So what will happen? Even though they are slowly dividing, but because of their prolonged survival, they tend to accumulate in our body. They have a tendency to accumulate in our body. And of course you understand that when abnormal cells keep on accumulating in our body, they kick the ass of normal cell. Yes. That they don't make the normal cell to work well.
Yes.
right? You will say, where is the ass and where is the cake? Answer is, all this is going in the bone marrow. When these cells will multiply in the bone marrow, they